So I'm going to talk about how to optimize a brain-dead donor, especially how to get more hearts from the existing donor pool. The background or the brief outline to the talk is why it's important, and then before I go into how to manage the pathophysiology of brain death, we need to know, and then give some trial evidence. And if you manage the donor early, means after the brainstem death is confirmed and the family have given consent for organ donation, if we manage the donor properly, we may be able to retrieve more hearts. As you heard, Andre was talking about, we are not doing enough heart transplant. So why we should do? Now, this is a slide from the International Society of Heart Lung Transplant, and you can see, although the numbers of heart transplant activity look stable, the yellow bars are shrinking. This is the activity of heart transplant in Europe, and it's much more exaggerated in the United Kingdom. As you heard, we did only a third of what we did a decade ago, which means we used to do 350 heart transplant. Last year we did 100 heart transplant. There is a constant imbalance between the supply and demand. As on the one side, we have a long waiting list, and also the patients waiting longer for a heart transplant, and they die on the waiting list. And the public expect us to do more transplant. On the other end, we have a poor cohort of donors who are older, because the mean donor age is increasing. Our donor age is usually around 40s and early 50s. They have hypertension, and they retrieve less from the existing donor pool. And if we do a less number of heart transplant, and if one patient dies, if you do 10 hearts and one die, it's 10% mortality. And if you go into 2 or 3 deaths, then it's a red flag. Your program is in trouble. So the retrieval team and the recipient team and the donor team are stuck in between. The only way we can actually break this circle is optimizing the donor properly and getting a good quality donor organs from the existing donor pool. So what happens during brain death? Why the donor organs are not good? We need to understand the pathophysiology of brainstem death. Now, it creates a havoc in a previously fit and well patient. He may well have a good 48-year-old man who is fit and well, but he gets a big intracranial bleed, and then 2 days later he comes, which is the foramen magnum push, the brain pushed through the foramen magnum or through the tentorium. It creates havoc. What happens is, when they develop brain death, series of events happen. One is a hemodynamic change, which is capital element storm, causing injury, a subendocardial injury to the myocardium, and the shear stress to the pulmonary endothelium, followed by an inflammatory change where all sorts of cytokines are released into the system, which leads to the lungs to be more leaky in endothelium, pulmonary edema. There is a hormonal change because the hypothalamo-pituitary axis is gone. There's no releasing hormones from the hypothalamus, so the thyroid hormones go low. There is no vasopressin. That means the donor starts to produce large volumes of urine, which is the diabetes insipidus. There's also biochemical change. So all these things affect heart and lung function, even in a previously fit and well patient. And if you have a background history of ischemic heart disease, hypertension, or if the donor has been on ventilator for a week in ICU, they're going to affect the heart and lung function. That's why donor management is important. In a study in Birmingham that I did, we have shown if you have a high level of procalcitonin, which is a marker of inflammation, the worse cardiac index and worse RV and LV ejection fraction. It's a great correlation between the high cardiac troponin high and worse cardiac index and LV ejection fraction. So now we know there is a problem. We have to do donor optimization, and we also understand the pathophysiology of brain death. So what is the principle behind donor management? There's no rocket science really. It's just simple attention to detail. What we need is somebody standing next to the donor, doing all appropriate things, making sure, accepting an adequate mean arterial pressure, start vasopressin so that the diabetes insipidus is corrected, so that you don't have to give large volume of crystalloids, give a meticulous fluid balance, maintain the blood sugar, make sure the donor is not cold, and continue to monitor the performance of the hemodynamic status. Why this is not happening in an ICU? Because the NHS-BT data suggests majority of the donors in the UK comes from hospital that encounters 2 to 3 donors a year. So the hospitals like Wigan, Bolton, or Brighton, I don't know how many donors Brighton provide. So you may have an intensivist on call that night. He probably had seen a brain dead donor 2 years ago. So he hasn't got that interest in it, and they don't have that idea that they have to do the basic things right. And we know from the Newcastle group study, which was done nearly 2 decades ago, that if you give a donor a large volume of ringer lactate, it causes pulmonary edema. So that's why starting vasopressin will avoid this large fluid shift, and diabetes insipidus will be treated and the donor becomes much more stable. So what happens if a donor is stable after the brain death, when you attend, accept a mean pressure of 65 to 70, their brain is dead. We don't need to aim to have a high cerebral perfusion pressure. So wean the noradrenaline, start vasopressins so that we can stop giving all the fluids. If needed, give colloids. If the hemoglobin is less than 10, give blood transfusion. Put a Swan-Ganz catheter, make sure you accept a preload of 12 with a 65 to 70 mean pressure. This was 2 decades ago. Derek Wheeldon from Papworth published this, and this is still a gold standard target we should aim. So what happens to hormone replacement therapy? In a donor, when we do optimization, we use 3 hormones, which is vasopressin. I have already mentioned about how good vasopressin is. The second one is steroids, methylprednisolone, and third is Tri-iodothyronine. So vasopressin, again the Newcastle group 2 decades ago presented it. It's very well known, and ADH is very good in the brain dead donor. It has no inotropic effect, and it makes definite stability on the organ donor and avoids the fluid shift. Steroids, because of their anti-inflammatory effect, they also helpful in fluid clearance in the lungs, because I mentioned the pulmonary endothelium becomes leaky, there's a pulmonary edema, so you give steroids early, that it does help in prevention of progressive accumulation of lung water. And finally, T3. T3, we know that brain dead donors, 85% of them have a low T3 levels. So if we give T3, even though we don't have substantial evidence to prove T3 is beneficial in donor, it might benefit the recipient because it has got an immediate effect and late effect. Maybe it will benefit the heart after ischemia reperfusion in the recipient. It may make the donor heart to be responsive to the inotrope we use. So echocardiogram, can we use echocardiogram? Again, in a trial that I did in Birmingham, we showed that the thoracic echocardiogram is very useful. It can identify major structural and valvular abnormality. It can identify LVH. And the one good point is, if you have an offer with an echocardiogram suggesting a good LV ejection fraction, no hypertrophy, highly likely that that heart will satisfy the hemodynamic criteria. Barring coronary artery disease, that heart will be usable. Now, do we have any evidence to say when you optimize a donor, it is beneficial? And I did a prospective study in 2006, which I finished, which showed that 6 to 8 hours of donor management prior to retrieval can make sure that we can wean the inotrope, the systemic vascular resistance can significantly be reduced, we can optimize the fluid balance, and we can increase the cardiac index. Not just cardiac index, all hemodynamic parameters could be significantly improved from baseline to prior to retrieval. And whether you administer tri-iodothyronine or steroids, this improvement in cardiac index persists throughout the during of donor management. This is a complex slide, but I just want to concentrate on the 80 donors we studied. 40 are suitable for at the end of assessment, and 25 are transplanted. Just want to show in the lungs that even though the lung function, it does deteriorate during management, I wanted to show you that administration of steroids helps to reduce the progressive accumulation of water. And we showed that 43% of the managed lungs could be used for transplant. So in conclusion, early management of a potential brain dead organ donor will increase the yield of both heart and lungs, and may even improve their heart function. In the future, we have implemented this in Manchester zone since last 15 months. Our attendance is 50% for all DBD donors. We retrieve 50% of the managed donors, and that led to an increase in heart transplant activity in the Manchester zone. The UK Scout Pilot project, which is now we're going to adapt what I had done as a research from nationally. From 1st of April, every unit is going to send a scout, which is a retrieval fellow, to the ICU to start the donor management early. Thank you.